Tonight, On Call, we'll explore the world of psychiatry. What goes on in our heads and why? The doctors are on call now.
Funding for this program is provided in part by
Avera is a proud sponsor of On Call on South Dakota Public Television.
and by the South Dakota Foundation for Medical Care, the Medicare Quality Improvement Organization for South Dakota. Additional funding provided by Dakota Care, the Brookings Health System, Regional Health, the South Dakota American College of Physicians, and Swiftel Communications. Closed captioning for On Call is provided by the generous support of Avera, the Brookings Health System, and Fishback Financial Corporation.
There's the valve.
All of them together.
And which was healthier, the yogurt and the bagel?
All right, I'm going to start by measuring the size of it.
You could also add grilled chicken to this recipe.
Blow hard, blow, 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 keep pushing.
And try to push your head.
Pull red handle to open bag.
Good evening. Mental disorders include everything from severe schizophrenia to mild anxiety disorders. Lately, we've been more attuned to these types of conditions as the men and women of our armed forces return from their tough overseas duty with post-traumatic stress. The causes for any mental disorder reflects both genetic predisposition and life experiences. Certainly, we cannot change our parentage, but we can make the homes in which we live more loving and supportive. We should do whatever possible to bring up healthy and happy kids, but despite every such effort, there will still be mental illness. Virtually every family has someone dealing with significant emotional stressors, and we all need to do better to understand why and how it happens, and how to best cope with psychological problems. To do this, we have invited Matt Stanley, psychiatrist and director of Avera Behavioral Mental Center, and Eric Kutscher, PharmD and psychopharmacologist, also of the Avera Behavioral Health Center. I invite you to call tonight, right now, or sometime over the next 1 hour with your questions about mental disorders. The phone number is 1-888-376-6225. Again, that number is 1-888-376-6225. So, and we need your questions, so please give it a call. Let's talk about who we are here. Eric, tell us a little bit about your experience and what where you come from.
Sure, I come from Chicago via Iowa City and Kansas City to Sioux Falls. I've been here for about 10 years now. I work at the Avera Behavioral Health Center, but I'm also employed actually officially by the South Dakota State University in the College of Pharmacy. And I teach psychopharmacology for the pharmacy students as well as psychopharmacology for the medical students at USD. And I direct the education there at the Avera Behavioral Health Center for psychopharmacology and the residency program for our pharmacists.
Right. I mean, that's a huge field,
Yes.
psychopharmacology, and it's extremely important as we care for people with mental issues. And so, do you live in Sioux Falls and then you drive up here to teach?
Actually, I teach in Sioux Falls most everything. I only come up to campus for student meetings and things like that. So my practice site and my teaching site is at the Avera Behavioral Health Center.
Great. And Dr. Stanley, tell us a little bit about you.
Well, Eric and I actually have a few common threads. I'm an Iowa boy, though, who graduated from SDSU and then went back to Iowa for medical school. But we actually spent time in the same facility. We were both at UMKC, or Western Missouri Mental Health Center, during a part of our training in Kansas City. And I've been with Avera here, 3 years residency, and then the last 15 years of practice with the mental health organization, which for Avera is quite broad. And as you know, we have a 110-bed psychiatric hospital there, which I'm now medical director of, and both Dr. Kutscher and I both do a lot of teaching with residents, and he also has the pharmacy residency, which we've now started, which is a big plus for our program.
So, I mean, I hate to admit this, that I don't know everything about every medication, and so I kind of lean on my PharmD that is in my hospital when I'm making decisions. Hats off to you, Steve. So I'm sure that there's that same collaboration that you two work together about. It's nice to have somebody whose job is the meds, and you're thinking, maybe, what do you think about this? And so that works that way, Eric, huh?
It does, and I liked your opening comments because I think they kind of led into that whole concept of the biology of mental illness. I don't think it's a concept that is still kind of gaining traction, if you will, that you talked about the genetics and the environment, the impact on that. I think Eric and I won't speak for Dr. Kutscher entirely, but I think we both come from a very biological perspective in terms of the treatment of mental illness, both how it develops, but how you intervene. It's these are illnesses based on kind of the lay term is chemical imbalances, and it really does get to, sometimes boils down to a chess match. If this neurotransmitter is off, how do we step in and reset the balance and then counteract how the body's going to react to that? So that's Dr. Kutscher's specialty, among other things.
Yeah, it's quite a nice collaboration. You talk about the pharmacist you work with and some of the general medical conditions. In psychiatry, it's really actually quite fun because, as Dr. Stanley said, you're looking at how does the drug work, what's going on in the patient with neurochemical and neurotransmitters, and what potential side effects could occur, and how is it going to affect other medications around with regard to side effects. So it almost becomes like a stew of medications that you're trying to nicely manipulate to see what is going to be the best for that person. And so working together as a team, Dr. Stanley could look at the psychological part of it, and what do we need to do? Here's what's going on, and then I bring in my expertise to work with his, and here's the medication that's going to be ideal for that specific individual, versus here's just a medication, take it because, say, you're depressed or anxious, but here's one that's right for that person based on what's going on.
And there's no question about it. Before the psychiatric medicines came out, we were caught with a large percentage of people with medical psychiatric problems that really struggled, and we had no good treatment for. On the other hand, I would make this comment. Maybe we go too far sometimes, that there's a time and place not to use medicine. Now, any comment about that?
I would agree. And I think I'd even add to that somewhat. I think through when I was in residency is actually when Prozac was first coming out. And, so we went through kind of the decade of the 80s and 90s, watching the development of all these new drugs. And I think that our hope and our expectation was, well, we're going to seriously cure mental illness or knock it down, to its knees. Unfortunately, we haven't seen that in terms of percentages. But I still think the perception is out there for a lot of folks that it is as simple as taking a pill. That's where we've struggled. But I think that's why you're continuing to see development and you're seeing new approaches. The Accountable Care Act is also driving changes in how we're looking at providing care. It's not, and probably never will be, as simple as taking a pill.
No, it will not be, will it? I mean, it's amazing. I have to say this. I think I was looking at trying to understand head trauma causing mental loss issues, and we had an expert come and speak to us at our hospital. And I had in my mind, this is it. This is your ABC. This is exactly how you do it. And when I got done with that, I realized, it's just not as simple as that. It's not a simple problem, and it's as complex as many people who have had it. And so we have to address those on an individual basis. Even the youngest of our population can have issues and stresses that we as adults have forgotten how important they are as we go through our busy lives. Deb Butman-Perkins is of the circle of encouragement visited with On Call about some of the concerns our children may have.
I see kids
I didn't go to
NCC,
LPC,
3 on up. My practice has pretty much evolved to that I just see kids and adolescents, which I think is a good thing that they have a space. It also is somewhat distressing because we have so many kids that are looking for help. I'm glad they have that. I see lots of kids with school issues, whether it be friendship, bullying, social things, academic concerns, lots of inattention. How do I get my stuff done? How do I balance school and everything else I'm involved in? I believe that kids are struggling a lot more with anxiety and depression than we as adults would like to think. Those things to look for when kids' moods change from what you normally see them, or that up and down mood swing. And again, that is part of adolescence and hormonal changes. But I think most parents know their kids pretty well. And if you see those concerns, ask them. Sometimes communication isn't the best with kids and parents. Many times when kids are acting out, they're trying to give us a message that they're hurting or they're needing something. And the majority of kids that I see are coming here very willingly. It definitely depends on what's going on. The way I generally work is I will meet with, sometimes parents want to meet with me and kind of give me some of the details without their child being there. And that's fine if it's a story they've heard a lot of times. They probably don't need to hear it again. But I want to always meet with the child and the parents, particularly an adolescent, to cover the confidentiality issues and how we will deal with that. And then I like to spend a few sessions with the kids and really get their story and get them to trust in this whole process. I found that kids very much will let you know if they need to come back or not. And it's been interesting since I've done this, since, almost 15 years now. I have seen kids at 5, and then I see them again at 9. And I just had a young woman find me. I saw her when she was 16, and she's 29. Even with anxiety and depression, I think we've kind of gotten oriented to, medication. We'll medicate things. And that's not always the answer. And even if it is the answer, which obviously, if we were a diabetic, we wouldn't think about doing insulin. But we sometimes don't think about that if our brain isn't producing enough of those happy, feel-good endorphins and neurotransmitters, why wouldn't we then think about aiding that with medication? And if that does happen, which oftentimes does help a child, I will still encourage families that, this is another good supplement to that medication. We can do coping strategies. We live in the Midwest, and we very much have a buck up, carry on attitude, and I think some of that comes from our heritage of very strong farm, rural-oriented society, which we've definitely changed, but I still think we have some of that concept of, it'll be okay, just get through it. If you had a broken leg, would you walk around on it and think, it's going to get better? You wouldn't hesitate getting medical care or glasses and it's funny because then when parents put it in that light, they're like, yeah, you're right.
That's a lot about kids and behavioral. Thank you, Deb, for that. As we were chatting behind the scenes, and we're talking about the drugs, and Eric, you made a comment that you're the anti-drug pharmacist. Tell us what you mean by that.
Well, I think oftentimes the first choice that everybody thinks about if there's an illness, no matter what it is, psychiatric or not, that we should give somebody a pill. And they oftentimes forget about all the other treatment approaches that are out there.
Such as?
Psychotherapy, diet, exercise, all those sorts of things. So medications just keep getting added on, and oftentimes the rest of their life is on hold, and they forget about how important those things are for their overall health and their mental health.
Yeah.
Well, there is no free lunch. Every medicine comes with a side effect. And a lot of times what we'll see working in the hospital is, obviously we see complex and difficult cases. That's how people end up in the hospital, and they end up there because they're not responding. We were talking, as you said, Rick, one of the things that is most satisfying to Dr. Kutscher and I is actually to remove meds and to clean up a med list and to focus it because you get such a mishmash of chemicals working in the body, you don't even know anymore what's side effect and what's original symptom. So, one of the most important and satisfying things we do is to actually pull back on meds and focus on other therapies and other approaches to treatment.
So I'm a big exercise guy. I think that I was kind of in a low level. I'm probably a little bit manic depressive, on a subclinical basis, and okay. So I've handled it by exercising. And it's been a huge thing to allow me to have a balance in my life. What's your comment about exercise as therapy?
I think it's a good thing. I talk with some of our psychologists that do behavioral therapies, and they're like, I wish I could just give people some of these studies that I have that show that exercise improves so many things. But unfortunately, sometimes their illness holds them back, and it's just getting them past that point to do it and just to reap rewards from exercise.
It's a hard thing to get people to exercise. It's hard.
Well, it's hard. It's hard to get people to do anything that's healthy. I mean, and you know, maybe that's why each of us has to kind of find our own coping skill, because you do what reinforces you, what you feel comfortable with. But as Dr. Kutscher said, I mean, there are numerous studies indicating that, you know, exercise itself releases or increases your level of serotonin, which is exactly what most of our antidepressants do. You know, there's numerous studies about reduction of anxiety through exercise. And this isn't necessarily competitive exercise. I mean, this is, as you said, running and, you know, just being in shape.
Or a mile a day. Walk a mile a day keeps the doctor away. You know, we'd sure encourage everybody to do that every day. A mile a day walk keeps the doctor away. We have another issue to discuss. Going off to college can be both a liberating experience as well as a stressful and frightening one. Deb Johnson, clinical counseling supervisor, and Brenda Johnson, psychiatric mental health nurse practitioner, work with the university students to help them cope.
As we see the students, it's a whole variety of issues, anything from transitions, homesickness, to much more complicated mental health issues.
When students come in, most often we hear complaints of either anxiety or depression, but then you really have to kind of do the drill down and figure out how that's really affecting their life, because it may be attention deficit disorder, it may be a true anxiety disorder or a depression disorder. And lots of times what you find is they're either having problems sleeping, problems concentrating, just a very low mood. Every once in a while you see the sicker student that has, you know, maybe even hearing voices, having suicidal thoughts, and that's when it becomes more worrisome.
Anytime that you're dealing with suicide, or even thoughts of death, or I don't know if I want to be here, or I feel like ending my life, those are times when you absolutely need to get some professional help. And so that would be a very clear marker of when you would make a referral. Other things are when the student maybe starts to isolate themselves, they're not communicating as well. If you notice that there is an increase in any drinking or any other drug use. Other areas, clearly, as Brenda talked about earlier, dealing with the sleeping, that's a huge issue.
You'll see students, their self-esteem really being affected, and almost lots of times what you see is paranoia setting in, like people are against me, no one likes me, or the professors are against me. And those are really barriers to education and making friends and that sort of things. Research shows that those negative thoughts really get hardwired in our brain, but they can be rewired to become more positive thoughts if they're challenged with psychotherapy and things.
Well, and that's part of what therapy does, is doing the rewiring of the brain. We also will work on coping skills. If someone has been using, say they've been using alcohol to cope, or they've been using cutting to cope, or sleeping all the time to cope, we need to replace that with a healthy coping skill that's going to help them to function better. And so we're going to work with that. A lot of the work that we do, because this is a very intellectual population, we use a lot of cognitive behavioral therapy, which is really changing the thinking and changing some of the thoughts. This is a temporary situation, and we're going to get a handle on this, and we're going to get a plan, and we're going to figure out what to do, and we're going to make it better.
So we've talked about cognitive therapy and rewiring. I know that it was maybe 15 years ago I was reading in the literature, don't drag up all that old memory stuff. Let's just treat with medicines, be happy, move forward in life. If you go backwards, it takes hours and years to help them in that manner. But now I'm hearing people are saying go back to it. What do you think?
Well, cognitive behavioral therapy is a specific approach, and it's, as you said, it's talk therapy, but it does differ a little bit than kind of, I think you're talking about more the process type therapy, the emotive therapy, talking about what bothers you today, how do you feel, the kind of classic, how does that make you feel, the classic joke of psychiatric counseling. But cognitive behavioral therapy is actually far more structured, and it takes your, as they were saying on the video shot, kind of takes your negative thoughts or your incorrect thoughts, makes you address them, bring them out in the light of day, and then tries to rewire, because most of these they're actually inappropriately critical of you. They're out of context, they're not accurate. So you correct that thinking, and then you, as they said, try to rewire or hardwire more positive responses or more appropriate responses. So it isn't so much dragging out what's painful to you or what's been hurtful. A little bit of that maybe, but it's really more focused on let's get to positive responses. Let's get to positive thinking patterns.
Right. Which makes the difference of a happy life. I mean, everything you read about how to be happy. They talk about think in a positive way. I mean, it's not a new idea.
No, absolutely not.
And it works. I mean, if you think on the positive side of things, then you communicate more. Let's just get to some questions. We've got a bunch rolling in. Post-traumatic stress disorder. Quickly, and I'd like, actually, you know what, I want to come back to that. But, well, say a word.
Well, we just, I was just talking to you before the show that we just kind of got to the 10-year anniversary of
9/11.
9/11, and and they just presented some information, studies on that, and it goes back to show us that although many people experience traumatic events, and we focus on those that are hurt by it with post-traumatic stress, which is extremely important, we can't lose sight of the message that the majority of people don't suffer post-traumatic stress. So it goes back to what you said. There is genetics, there is environment, there is, an illness kind of has to land in the right
fertile
bed, right, for it to grow. And so the thing to remember is that people may have the same experience, but someone is going to, be traumatized by it and have a lifetime of difficulties or a long period of difficulties. Another will go through it with very little difficulty at all.
And it is a genetic thing. I mean, a lot of that is genetic.
And there's a lot of factors, and they're interesting. We don't necessarily know what they all mean, but even things like educational level, socioeconomic level, those have an impact on your likelihood of developing post-traumatic stress after an event.
So what would be the most powerful environmental factor? Being held by your mother as a baby, or getting positive, is there one thing or maybe two or three that are the most important that brings us a environment that's important?
I don't want to pretend that I can answer that accurately. Yeah. So whatever I say will be a little bit of a learned assumption. Or
but say something.
Well, I would say that genetics are probably still the biggest factor and probably the one least under your control. But if you were going to look at environment, it probably is.
Very early.
A precedent of a very successful, very nurtured, very positive childhood, activities, education, loving family, all those things would set the background for you to be the most successful in terms of coming through a traumatic event unscathed. But having said that, even those folks could be traumatized.
Yeah. I guess I would only say this, as an old guy, well, not that old, well, kind of old, I still can be aided by a loving environment. It makes my life so much better. And that comes from my spouse, from my mother, from my friends. And that makes a huge difference in my life still. Now, Eric, you've been out of the loop here. What?
Oh, I agree. I was just thinking, on the news on the way up today, they were talking about the exact same thing, but looking at the risk of substance abuse and different types of abuses that people might do with alcohol and things, and just having that family relationship and actually having meals together and doing things as a family unit seemed to significantly decrease the amount of other illnesses that are related to substances.
Right.
So here we have a psychiatrist and a pharmacist talking about eating together as a family.
Yeah, there you go. I think that's so good. Read to them. Read to those kids. Yeah. But that's a far piece from post-traumatic stress syndrome, but we can go back. Curious about borderline personality disorder. What is borderline personality? I mean, my thought is, that's where we take the Hitlers and the Gaddafis and we look at people who are bad and we say, they've got a personality problem.
Well, personality disorders are a pervasive way of responding to people in situations, and we don't really diagnose them until you're adult because we view adolescents and children as being a little more malleable, plastic, still in the development age. But personality disorders, there are a number of them, and borderline personality is just one of them. It's actually, we cluster them, and cluster B is borderline personality disorder, narcissistic personality disorder, histrionic personality disorder, and antisocial personality. I would argue that probably Gaddafi and Saddam Hussein are more on the antisocial than the borderline. Borderline is actually it's a highly treatable condition now with a form of therapy developed called dialectical behavioral therapy. So, if you would, something of an offshoot of cognitive behavioral therapy, but with specific approaches again, and actually developed in part by Margaret Linehan at the University of Iowa and others. But so borderline personality disorder, one of the hallmarks is kind of a fear of rejection or fear of being alone, and it pervades all their relationship interactions, leads to kind of a chronic unhappiness, dysthymia, that kind of thing. Okay.
Wow. The simplistic pharmacist view is everybody has their personality, so it's just a different personality that gets diagnosed. So, it's not that they're that different, it's just that it's a diagnosable thing that has symptoms that oftentimes requires different types of treatment. So there are specific medications that sometimes we'll use, and it oftentimes looks a lot like other illnesses, anxiety disorders, depression.
Right. Looks like a lot of different.
Looks like a lot of other disorders.
One of the things we tell our residents in the hospital is don't be too quick to diagnose personality disorders, because people under stress or when they're very ill will have different responses, and oftentimes we actually regress in terms of how we cope or our defense mechanisms when we're under stress, when we're in severe depression or severe anxiety. So
we all reach a breaking point where we may go off into an area that's not quote unquote normal, depending upon the stress that we have.
Right.
What about medication for PMS? We've got a question here. Should hormone treatment be considered as a precursor to treat depression caused by PMS? What's your comment? Do you have any statement? You're the PharmD.
I think there's some data about different types of hormones, but there's not a lot of good data. Usually the hormone data, you have to go in and get your laboratories tested. Women have to get their estrogen levels tested and try to balance it with the different types of hormones, so you really need to see somebody specific to do that. There are some data on oral contraceptives, helping balance some of that can prevent it. And also there's some things on, antidepressants, fluoxetine or Prozac, for example, that can help with some of those symptoms that go along with it.
There's some really clear studies with antidepressants. One of the intriguing things now is some of these birth control pills that can essentially, or not pills necessarily, but birth control forms that can essentially wipe out your menstrual period for a year at a time. Yeah. So those things are to be considered. It is the hormonal flip that occurs between estrogen and progesterone that we think triggers that PMS. So it does tie back to hormones, but antidepressants are beneficial, and
all kind of people talk about Effexor instead of the SSRIs and SNRI.
But the interesting thing about that is Effexor as an SNRI really doesn't become an SNRI until 150 milligrams. So up until then, you're primarily an SSRI, because it's an interesting drug. As you increase the dose, you pull in the norepinephrine effect. So a lot of those studies, although Effexor is used, it's actually, from a chemical standpoint, working just like an SSRI. It depends on dosing, is what I would say.
So one quick word: SSRI, serotonin enhancer; SNRI, serotonin and norepinephrine. Quick word of what each do.
I agree on what Dr. Stanley said. All the SNRIs that are used for this types of symptoms are usually SSRI doses, so the lower doses, and it's a serotonergic thing that seems to be causing the problem.
You raise the serotonin,
you raise the serotonin,
life is better.
It seems to improve and balance some of the hormones and some other things that are going on in the central nervous system to kind of help provide a little stability.
And those drugs work not by putting in serotonin; they just enhance the serotonin that's made by the natural person.
Yeah, so essentially they help your body reuptakes whatever it produces for neurochemicals and destroys it. So what the serotonin reuptake inhibitor drugs do, like Prozac, Paxil, Celexa, they block the pump, sort of the vacuum that sucks up all that stuff and gets rid of it, and it helps keep it out there so your body could use it.
So it floats in the synapse longer, it's more likely to connect to the receptor and send the signal downstream.
So there's a new one out with 2 eyes. Does that actually work a little bit better?
I haven't used it yet. Here's what I would tell you. There's a couple of interesting, I niche is probably not a great word. There may be uses for that drug, but it's more in terms of we have all the antidepressants we have, none of them have ever been able to establish a better efficacy than any other. Right. So what we're looking at when we look at which antidepressant to use is which side effects can we avoid, or which, you know, which interactions do we have to avoid? Yeah. So, and that's exactly what with this antidepressant. It isn't that it is going to be a world beater and that it is the best antidepressant by 20% statistically. It's going to be what niche does it fill? Who can use this now? Who couldn't use the others? Or
all right. One of the problems that Debra Johnson, clinical counseling supervisor, and Brenda Johnson, psychiatric mental health nurse practitioner, who you saw earlier, see often is eating disorders and how they manifest themselves with patients.
We sometimes see eating disorders here, and we work as a team approach with that. We may involve someone from medications, but we certainly use the therapy. We have at times had groups that can be helpful for individuals that are handling that situation, but we also work with the dietitian.
And with eating disorders, you always have to look for other mental health disorders, depression issues, anxiety issues, trauma issues. We haven't talked much about trauma, but people that have had sexual abuse, physical abuse, emotional abuse. I think lots of times if sometimes they kind of repress that and they do well for a while, and then all of a sudden they have overwhelming anxiety issues, and some of those issues can turn into eating disorders. And so again, it becomes the important part of the assessment to really find out those issues and try to see what we're all really dealing with.
Any comments that you would have about eating disorders, the two of you? It's a real deal, particularly in young women, probably more than men, but both groups.
It is difficult to treat. I would agree with what was stated before. You know, it's a team approach. You can't. In other words, it's another one of those illnesses that you're just prescribing a med, or even prescribing a behavioral intervention all alone is unlikely to succeed. You really need, and for many folks, as the eating disorders are interesting. The worse they get, the further the illness goes. Again, it goes back to that how it's changing the body's metabolism, and it becomes delusional. In other words, you can sit two girls down, both with severe eating disorders. The one would be able to look at her partner in the group and say, she's too thin, but I'm still fat. So you can see it in someone else, but sincerely believing that they still have weight to lose. And it becomes delusional, although antipsychotics really haven't been successful. So there are changes, and that lack of protein, the lack of glucose, there are major effects on the brain. And that's why a lot of times it does cause hospitalization. It's also, it has a pretty high mortality rate.
Well, the thing I worry about it is that if it gets started, it perpetuates itself, and it kind of snowballs. The more you do it, the bigger of a problem, and the harder to get out of it. Exactly. You get caught into a trap. Am I wrong on that?
Yeah, it's like obsessive compulsive disorder almost. You get into it, and it's sort of like your compulsion. Then you obsess about it, and you compulse and continue with it.
I have a patient, by the way, with obsessive compulsive disorder who dearly love this lady. It's just a sweet, kind, gentle person, but she's so caught in it. And she's getting better, but it's so hard. I mean, it's a tough deal. And she'll struggle with this all her life, I know.
It is, and obsessive compulsive disorder is one of those. Anxiety disorders tend to start earlier, probably, particularly than major depression and some of the schizophrenia. So a lot of these people had it through childhood, and it just progresses. For the obsessive compulsive disorder in particular, kind of a lifetime disorder for a lot of folks.
It's hard to get escape from it. Yeah. I'd like to know about pornography addiction and its treatment.
Well, and I won't pretend to be an expert on that, but I will talk about addictions in general. I'm a little bit on, what would you say, on the fence as to whether I would consider that an addiction or not. I think there's people who very firmly do. An obsession might be a closer observation, but there are a number of different ways to approach it. There are some self-help groups for, you know, the sexual addictions in general. I don't know of any that are specific to pornography. Medications might have a role if it has that obsessive piece. Not particularly specific to pornography, but in some sexual disorders, we will actually, or have actually used even hormonal therapy actually to reduce testosterone and do some of those things. That's a relatively drastic step, but so I would say the main thing is, you know, with any addiction or behavior that you are concerned about, is to acknowledge that it is a problem in your life, that it is affecting functioning either with family, friends, spouse, however, and begin with counseling and kind of move through the steps from there.
Yep. We speak about addiction, and certainly addiction to not only pornography, but addiction to gambling, addiction to alcohol or drugs, is stuck on something that you can't get out of. And you tie them together to some degree?
I tie them together. I think we can tie them together relatively neatly through a neurotransmitter, dopamine. Almost all addictions involve a desire to elevate dopamine or to affect dopamine, and but other neurochemicals are involved. And actually, it's interesting because we said earlier in the show that pills aren't the answer to every illness, but there are actually treatments that are getting better or more useful in things like alcohol addiction, in which we had. I mean, we know of antabuse, which basically blocks the metabolism of alcohol, and so if you drink, you get very, very ill.
Yeah.
But we're talking about a different level, like the acamprosates, dealing with neurotransmitters like GABA and glutamate. So making the withdrawal and the cravings actually impacting some of that. But if I were to tie together all addictions, I would say dopamine. It was nicotine, alcohol, stimulants.
Dopamine is part of that. And if we could find a drug that raised dopamine, does that help?
I'll give you an example. So Wellbutrin is, we were talking about SSRIs, SNRIs, working on serotonin and norepinephrine. Right. Wellbutrin is an antidepressant that works on dopamine and norepinephrine. So can you tell me what Zyban is, the anti-smoking drug?
Yeah, well, that's
Wellbutrin.
It's Wellbutrin.
All they found out as people were taking Wellbutrin, they had an easier time quitting cigarette smoking. So, being a great marketing company, said, all right, we'll take the same drug, we'll call it Zyban, right. We'll sell it. But it affects dopamine, and that's how some people, not everyone, are more successful at being able to stop using nicotine.
And you got to be careful, because there are drugs for restless legs that actually augment dopamine in a different mechanism, and actually they start getting some sexual addiction type stuff, and they start gambling and doing different things. So if you talk to a neurologist that treated restless legs, they notice these people are doing unusual things.
Well, that's the classic L-Dopa. The old guy who has Parkinson's disease, he gets the L-Dopa and he goes after the nurse. I mean, that's a story.
Yeah.
I haven't seen that.
There actually is an FDA warning on those restless leg medication. Actually, on gambling is what the warning is out on. So another one of those kind of little chemical changes, maybe going under the wire. I started this drug, and now all of a sudden I'm spending money and gambling. It's like, well, it's actually hard to believe, but that medicine you're taking at night to help you sleep has made you increase your gambling.
Now, there's a question from here: is narcissism a mental illness, or is it a personality disorder, or is?
Great question. Let's answer it in phases. So, so narcissism is a trait. Narcissistic personality disorder is
a mental
illness, and it is a personality disorder. So basically, where you cross the line is when.
So what is narcissism?
Well, it's after Narcissus, who stared at the pool at his own reflection, and he was so in love with himself. So it has mythological roots in the title, but narcissism is basically self-love. But where you draw the line is on between whether something is a trait or a disorder is, does it affect functionality? Can you still maintain relationships? Can you still work? So it's kind of like, if you remember, I think this will resonate with you, Rick. When you're reading about illnesses in medical school, you're like, oh, I have that. Oh, So when you read
Why do you think that would affect? Hello.
So when you're reading about personality traits, you say, yeah, I've got some of that. Yeah, I've got some of that. Well, we all have personality traits. It's like Eric said earlier. But when it gets to be a disorder, that's when, it's affecting your ability to function.
That's it. Here's a question. What is the prevalence of alcoholism and binge drinking among students? And then correlate between alcohol, and talk about alcoholism versus binge drinking.
I think it's hard to define. There becomes more and more studies about that. We were just talking about it a few weeks back, and I know there's a study that just came out looking at which universities had worse rates of binge drinking. Or actually, where we went to school there in Iowa seems to rank on the top of the list for some reason. I don't know.
It didn't happen in South Dakota.
No,
but it happens in Iowa. I'm sure that's the case.
Happens in other states.
It's really difficult. I can't remember exactly the rate, but it's difficult because anytime you try to rate on what the prevalence of any substance use disorder or what people are doing, oftentimes it's really usually underrated quite a bit. As for the prevalence, I think it varies on geographical region. I can't remember exactly the percentage overall. If I did, I'd probably be wrong.
But there's plenty of it.
There's plenty of it, yeah.
Any more than it used to be? Hard to know.
I don't know.
Not specific to alcohol, but recent data, it showed a slight decrease in overall illicit substance abuse, except for marijuana. So, but not enough necessarily to trend. So,
okay.
And that's not specific to alcohol.
All right. The ultimate effect that mental disorders can have on a victim is death. When someone attempts suicide, it may be a cry for help that they are discovered by family or friends before they die. However, there are times when the desire is to have the final release from the illness that is tormenting them to the point of self-destruction.
She suffered quite a bit from anxiety and would talk about like anxiety attacks. She started seeing a psychiatrist when I was young, probably, I don't know, elementary school or so, and it really wasn't an issue. We didn't know too much about it other than she went to go see this doctor and it was just therapy. So it wasn't anything we knew to be serious until I was a freshman in high school. She was in and out of hospitals, gone to see her in psychiatric wards, different treatment programs. She had electroshock therapy at one point, which was pretty disturbing because she didn't remember that she had kids. My mom's first cousins, they suffered from mental illness. One of them committed suicide when she was younger, so when I was young. So there was always some specter of mental health issues in the family. I was a senior in college. It was 1983. It was just your normal college weekend, and the phone rang, and it was my dad, and he said, he said, Mom died, and I just, and I was like, what happened? And then he said, she killed herself. We were living in a high-rise condominium, and she jumped out the window. We were on the 14th floor. I mean, 1 second, your life is going along, and then the next second, it just totally turns upside down and inside out. And I mean, it's just really, really hard to wrap your brain around. And to this day, whenever I hear about another suicide, my heart goes out to them because I know, you know what those people are about to go through.
Well, I sense that is so true, and thank you, Amy, for your willingness to do that very heartfelt comment. I think about death in the family. I had a death in my family, but there wasn't a suicide. I know how devastating that is to families. I cannot imagine. I mean, it makes me mad at those people. I feel anger when I see a suicide, and the families, torn.
Well, I think you just hit on part of it. I think it's so confusing when a loved one, you should feel sad, but you also feel angry. You feel guilt, like, I would have done anything if they just would have come to me. So, it's just this mixture of emotions that are hard to sort through. Bereavement, getting over the death of a loved one is hard enough anyway, but when it comes unexpected and you feel like it was preventable, and like if they would have just reached out we could have taken care of anything. And a lot of times, and I know, she was speaking of her mother, but a lot of times with younger kids, you almost feel like it's an impulse. Like if they'd have just waited another 24 hours, the world would have looked different. So it's all those things make it so difficult, and it's it's the pebble dropped in the pond. The ripple effect is just devastating. Yeah. Everyone is hurt, and it isn't the kind of thing that you work your way through in a year or two. No. It's a lifetime
working through.
Yeah. I think that's something that's important for everybody to know. If you have a family member that has those feelings, when they're getting assistance for medications, that the medications take a long time to work. So sometimes people get really discouraged that it's not working in the first couple of weeks, and I still have these feelings. You've seen the warnings about suicidal rates and things like that with the newer with the medications. I think it's part of it is that I'm not getting better, and I think I should be better. This is supposed to be the pill to fix me, and they don't give things time, and they need to talk with their providers and their families to say, hey, what's going on? Do you notice that I'm getting better?
Yeah. Now, there's a lot said about the medicines causing suicide. Mm-hmm. And the studies show that's not true. The people that are on the medicines have less suicide than the ones without it. But it's still, while they're getting better, they seem to be able to bring to action the suicide. Any comments about that? Would you say that again? Because people need to hear that.
Back in 1980 when Prozac came out, the same thing. Take Prozac, you become suicidal. Now, it has come back. It's not that they have suicide, as they might have maybe more suicidal thoughts, but generally what it is they think they should get better faster. So they don't give the medications long enough, and oftentimes the medications they've never had before, so there might be an acute side effect. They might feel a little tired. They might actually feel a little anxious from the medication, and they feel like, wow, I'm getting worse with the medication now. And sometimes, they might have the will to do it. And the other thought is that they start getting a little bit better in a few weeks, and now they have a little bit of energy, but they still feel depressed. So they have the will to go maybe forward with the act. Now, all the studies showed that nobody committed suicide. It was just a thought that occurred. And if you look at suicide rates over time with antidepressant prescriptions, the prescriptions go up, suicide rates go down. So, but since the warning, it's switched a little bit. They can't prove that the warning made that happen, but I still think there's something there. Over time, when antidepressant prescriptions are there, suicide rates do decrease.
They do decrease.
Yeah.
And just to be clear, the black box warning that was put out was adolescents and young adults, mm-hmm. So it's age related. There truly are. A percentage of people that the antidepressant seems to generate the thought, but not the action, right. Which is a very clear distinction. And in fact, STAR-D tracked down with Celexa, again, we go back to some genetics. There was a very small percentage that seemed to have a genetic abnormality that with a certain antidepressant it would trigger that thought. But again, it was a very small percentage of people.
Now, as long as we're talking about SSRIs, I read recently that people who are on SSRIs, this is off-label use, I'm not recommending it, but they found that there is less Alzheimer's disease in this group. I'm quick to use antidepressants in people who are early Alzheimer's and would add that to the other medications. And I do it with Parkinson people who are depressed too. Any comment quickly?
Hey, you'd mentioned that earlier, so I had to do a quick search on my way in. And there is some studies out there in rats that they induce Alzheimer's-like properties, and that seems to decrease some of the plaques and tangles. And there's actually a study in humans. I think they had 100 people with Alzheimer's, and they looked at the ones that were on antidepressants. They actually had less of the plaques, and I think for sure the plaques and some of the beta amyloid proteins that go along with Alzheimer's, leading to the thought that maybe decrease some of the incidence or maybe some of the impact that Alzheimer's could have.
So although I'm not a pusher of drugs and I like to do the non-medicinal things, but I am less reluctant to use SSRIs, particularly in the elderly, when there might be some Alzheimer's disease. Is there a quantitative test like the system in diabetes to measure for depression? So that we could better define what kind of level of depression there is?
Great question, and probably one that everyone is seeking when they come to the hospital. Test me and tell me what's wrong. In research, there are some metabolites of certain neurotransmitters we've talked about. Some things that can show lesser quantities, but there is no specific blood test, no specific level of a neurotransmitter that's available to us to administer to you, to give you a reading and say you're in the abnormal range. So unfortunately not however, you know, Eric and I, both are involved in research. We're both trying to get to that point, as is the whole country. So I think that as part of personalized medicine, if nothing else, we can now at least identify some of the risk factors genetically.
Okay. As we close tonight, the Homespun Medical Essay looks to mental disorders. There is no shame when people have to deal with physical illness. So why are folks so reluctant to face mental illness when it occurs in themselves or in their family? I have no problem with telling you that in my lifetime I have had a fractured clavicle, childhood asthma, pneumonia, adolescent acne, inguinal hernias, and eye trouble. For each of these I found medical and or surgical help. Yet why am I so reluctant to admit to you that during my college years I struggled with some depression, or even that many years ago my grandfather died in a mental institution? Every one of us can speak to our lives' experience with physical problems, but we would hardly admit to having some encounter with emotional troubles. In our society, psychiatric illnesses and psychological struggles have unfortunately and unfairly been tagged with guilt or shame. And this goes doubly true for the male of the species. I would submit that we are all thrown off balance by one kind of psychological challenge or another as we struggle through the normal encounters of daily living. Who hasn't been profoundly depressed by the loss of a job or stressed out by the demands of a new one? How does anyone handle the severe illness in a child or a spouse or a death? Who faces divorce without anger and disappointment? How do we live through financial loss without fear and anxiety? Life is often very difficult. Every individual copes in a different way, and sometimes it isn't pretty. But mental illness doesn't have to follow a stressful situation. It often occurs without a rhyme or reason. Like adolescent acne or acute appendicitis. Schizophrenia, for example, happens spontaneously without warning in the best of families. There should be no blame or guilt, and yet an unjustified disgrace of having mental illness often prevents timely and effective treatment. Bottom line, every one of us deals with sometimes minor, sometimes major physical and or mental illness through our lifetime. We should realize that it is smart to seek help not only for physical but also for emotional challenges each and every one of us have to face. There is no shame. Any agreement or disagreement on that, Matt?
Oh, I just want to reiterate, I'm 100% on board with you, and I think that's one of our biggest messages. If Dr. Kutscher and I could say one thing, and it's been evident throughout the conversation, these are biological illnesses, many of them genetically driven. Environment impacts on that, and you end up with an illness, just like diabetes, just like anything else. There is no stigma, there is no shame. Get help, and you know what? There are constant advances in treatment. So, you know, it is, to us, it's a medical illness. There is no difference. I'm part of a medical campus. I'm a physician. Dr. Kutscher spent his entire education learning about
medicine.
So I just want to reiterate that it's if there's one thing we could emphasize today in this hour, it's that message.
Great. Eric, comment?
I agree 100%. You know, the stigma is the problem, but there shouldn't be a stigma, just like every other illness. And the other thing I encourage is search around for providers. You should be able to, anybody should be able to find someone they could talk to about this. If people feel uncomfortable talking to their physician or anybody, find somebody else.
Yeah.
You know, you should have your pharmacist, nurse at the office. Everybody should be on the same team with you to help you. So you should feel comfortable talking to everybody, because they're a good resource to help you get better.
Yeah. If you're feeling somebody's talking down to you, get another person, because they've got a mental problem themselves. Yeah. Quick question about, here's a question about pain medicines leading to depression, benzodiazepines causing depression, other medicines causing depression. Any comments?
Well, pain meds, no direct correlation. However, what we would say is pain is directly correlated to depression, but a lot of medications will create side effects that mimic symptoms of depression. Pain meds, for instance, sedation, cognitive confusion, I wouldn't say that it's necessarily the med that's causing it, but meds can certainly cause poorer function.
Yeah, I agree. You really need to look at the medication and the side effects, because oftentimes the side effects might, give the impression of depression, or maybe just brought out the symptoms that were already there with the pain.
And I see a lot of medication we do for pain that really brings on a little bit of Alzheimer's that we may have. Well, I want to thank you very much, both of you, for your time and your effort, your volunteer for being here. Thank you all for watching. Thank you for calling in. Until next time, be healthy out there, people.
Avera is a proud sponsor of On Call on South Dakota Public Television.
And by the South Dakota Foundation for Medical Care, the Medicare Quality Improvement Organization for South Dakota. Additional funding provided by Dakota Care, the Brookings Health System, Regional Health, the South Dakota American College of Physicians, and Swiftel Communications. Closed captioning for On Call is provided by the generous support of Avera, the Brookings Health System, and Fishback Financial Corporation.